Thank you for joining us for the second annual Global Summit, Global Kidney Innovations, Expanding Patient Choices and Outcomes. This is a collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. I am Kent Bressler, a retired registered nurse with 22 years as an RN with the Veterans Administration and 20 years in the private sector. I proudly served in the United States Army Medical Corps from 1970 to 1972. I have managed kidney disease for over 40 years and received a kidney transplant from my brother, Kip Bressler, 33 years ago. Mentoring those with kidney disease and advocating for preemptive transplantation is my passion. I am honored to serve as an AAKP ambassador for the state of Texas and as a member of the board of directors. I appreciate being able to represent AAKP as they represent and serve the many kidney patients across the globe. Today, I'm pleased to introduce Dr. Neal Sikka, Associate Professor of the Department of Emergency Medicine, George Washington University School of Medicine and Health Sciences. He will present on coronavirus, transitioning patients from telehealth and telemedicine back to in-person care. We appreciate Dr. Sikka for taking this time to share his insights on telehealth and how timely research and innovation can improve the lives of patients and society.
Thank you, AAKP and GW, for inviting me to join your conference virtually. My name is Neal Sikka. I'm a practicing emergency physician and professor of emergency medicine at the George Washington University. I'm also serve as the chief of the section of innovative practice and telehealth, our team that works on utilizing physician skill sets in unique and innovative ways outside of the hospital in many cases. At GW, we are a large multi-specialty group practice, and through a large team effort across our organization and our partners at the university and the GW hospital, we've organized a number of rapid COVID response actions. We briefly walk through these programs and share with you how we responded to COVID on our campus and within our community. And then we'll finish up with some thoughts from here. As first-line workers and emergency responders, early in February, we started to think about how we would respond to COVID. So we reached out to our emergency services personnel within the city in DC and developed pilot protocols that enabled our EMTs and paramedics to collect NP swabs and administer vaccines. This type of scope of practice did not exist in our city's existing EMS protocols. And our emergency response leadership was incredibly supportive in piloting early and aggressive responses to COVID that will set the stage for a longer-term community paramedicine program. It was important for us in the support of new initiatives to develop appropriate training, specifically in this case for collecting NP swabs for COVID testing, as well as safe donning and doffing of PPE. So we developed rapidly a certification program and then expanded the scope for a large cadre of healthcare workers, beginning with our EMTs and paramedics to nurse practitioners, PAs, and even physicians who would go out and collect swabs in rapid testing needs. We also needed to enable telehealth to preserve PPE. We were concerned that early PPE shortages that we were hearing about could affect us, and we wanted to make sure we learned how we could utilize telemedicine to preserve PPE for the long term. In conjunction with EMS efforts that we pitched to our city, we also proposed the rapid deployment of a COVID-19 call center, a general question line that could respond to our city's residents' questions related to this new and emerging disease, as well as offer a human that could help screen residents for COVID and whether they needed testing. We developed and utilized simple technologies to build algorithms that helped our operators respond to general inquiries and screening in a uniform and consistent way, and then be able to escalate those patients who might need to speak to a physician back to their primary care provider or to one of our emergency medicine telehealth providers, who could then do a video or telehealth consultation as needed. Testing has been a massive and important component of the COVID response. And now we had enabled a mobily trained and expanded workforce that allowed us to develop testing at the right time and the right place. So we targeted a number of types of locations. For example, we initiated testing for PUIs at their own homes. So we sent strike teams, or what we called strike teams, out to patients' homes in pairs to do swabs right at the doorstep and eliminate the need for those who could be potentially contagious to have to leave their homes and expose other people. We developed walk-up tent testing on our campus, a drive-through testing center on our campus, as well as large teams to go into nursing homes and test nursing home residents en masse of 100 to 200 patients at a time for COVID. In addition, as things have the COVID pandemic response have continued over a long period of time, we've also started to provide testing at client sites for responses to clusters of infections, as well as to support reopening. PPE conservation is extremely important, especially in our hospital setting where we're seeing large numbers of COVID patients. And so we decided that we could utilize video to allow our ED team members to participate in evaluations, but only have one person have to actually go to the bedside. This was especially important in our teaching or academic environment, where we often utilize a team of a resident and a senior resident and attending physicians. And we actually found that this could be potentially advantageous from a teaching perspective. How often do trainees get to closely observe faculty taking a full history and physical exam and then be able to add to that? And in the opposite scenario, how often do the faculty get to observe their trainees take a full history and physical and then add to that? So video was actually very enabling for both teaching and PPE conservation. We also brought our in-house specialist into the ED virtually. So for example, in psychiatry or stroke response, our specialist could be in safe zones within the hospital, still respond to patients who are potentially infectious. Over time, we began to see patients who were diagnosed with COVID actually start to return back to the emergency department with worsening COVID symptoms. And in response to this observation, we launched a remote monitoring program. We were able to discharge patients home with medical devices and have them report their symptoms on a daily basis. This was based on work we actually did with dialysis patients back in 2012 to 2015 through a Center for Medicare and Medicaid Innovation Grant, where we were able to demonstrate that home remote monitoring with patients, especially for blood pressure and other symptoms that might relate to their catheter site, for example, could be evaluated using video, and the actual act of monitoring them remotely could provide beneficial feedback and provide better blood pressure control. So in our specific program, this slide just demonstrates the questionnaire that we designed based on mostly common symptoms related to COVID. And the patients were able to enter the readings from the thermometer and pulse ox they took home and then respond to this form. On the back end, in our telehealth call center, we had EMTs able to observe the data as it came in and utilized rules within our software to escalate those patients who were reporting abnormal vital signs or worsening symptoms. And here you can see this patient's daily reports of heart rates and pulse ox parameters. Our dashboard allowed us to basically categorize patients into two groups. One, those who responded to the emails, And then the group that, and the ones who did not respond to emails needed to get phone calls back to check on those patients. And then the group that had abnormal or worsening symptoms, and those people also required a call back to check on them and make sure they were doing okay. If the EMT was unable to resolve the problem, maybe check on the patient and determine that the reading was taken incorrectly, or a heart rate was measured after significant strenuous activity, then they could escalate them to our telemedicine doctor, who could do a video visit and further evaluate the patient to determine if they needed to return to the ED for further evaluation. We found that about 15% of patients did need returns to the ED, but a large percentage of these escalations were adjudicated remotely. As I mentioned, we're part of a large and multi-specialty group practice, and early on, in late February and early March, we were recognizing the need that with social distancing, the risk of infection in large group settings, that we would need to shift our practice towards telehealth. Fortunately, we had a long experience providing telehealth services within our practice. However, it was not geared towards more local and regional care due to many restrictions in place by CMS rules for telehealth in urban areas. Many of you may see that same challenge or have seen that same challenge. But as the pandemic response increased and the public health emergency was declared, the waivers associated with CMS enabled us to rapidly deploy a HIPAA-compliant telemedicine solution, mostly based on video, to help support our patients who are at highest risk. This was driven actually by our specialists who are taking care of patients who are often immune compromised or have multiple chronic conditions or comorbidities that put them maybe even higher risk for complication. So we developed the capacity and took this enthusiasm among our early adopter physicians to launch telehealth, and then used those early adopters to serve as trainers for a second cadre of providers to come on board. And pretty rapidly, we had over 400 to 500 physicians providing telehealth services. I think one of the most beneficial components of providing telehealth services rapidly was that our patients saw that we were there to support them during this difficult time. And we started to see that our physicians, and especially our specialists, recognized that they could actually provide services through telehealth. While they may be limited in certain conditions, they were starting to recognize how telehealth could meet many needs of their patients, including COVID screens, but also routine care, urgent care, and specific to kidney care, we provided in-center dialysis that was supported through telehealth. Also remarkable in the telehealth response was the very low cancellation and no-show rate. Often our practice could see up to a quarter of patients no-showing, and we're pleased to see the response was quite high with telehealth. With, as you can see in this slide, at that point, only 4% of patients no-showing or canceling. So in addition to our practice response to our patient base, we felt it was very important to have community-based education related to digital health tools. This type of community engagement started prior to the COVID era, where we had learned that as we built capacity to reach out to our patients through telehealth and other types of enabling technologies, that often if you build it, no one would come. And we felt like this was based on poor health literacy and poor digital health literacy. Patients often did not trust technology. They may not be comfortable with its use. They may have concerns around privacy or security. And so we developed a very high-touch program based on the model of a Apple Genius Bar, where your experience is such that if you have a technology problem, you walk into a store, you have a clean experience that leads right to a genius who can help resolve your issue. In the same vein, we developed a community-based model, a pop-up type of community event where volunteers from our community who joined our program called the Health Desk were trained to be digital health coaches. And they were partnered with students and other staff from the faculty to do peer education one-on-one with residents in often underserved and highly Medicaid populations. And we were able to teach people how to use their phone to leverage their own health data, to own their own health data, and to be better connected with the healthcare system. So we felt like this type of community education is critical to enabling long-term use of technology. Now, in the era of COVID, this high-touch model has to be adapted, and we're looking at how we might build a cadre of online services that can mirror the services we were providing in person before. While many organizations have responded to meet the needs for COVID, there are a number of key enablers of rapid changes, and these include, probably most importantly, the government's response, the CMS emergency waivers related to telehealth, remote patient monitoring, by liberalizing many of the restrictions that we had known for telehealth, especially services based at home, services that had been limited to rural areas only, as well as licensure reciprocity. On the RPM side, they enabled the opportunity to now provide remote monitoring for acute conditions and not just chronic conditions. So both of those, you can see, enabled the programs that we initiated and allowed providers to use once restricted tools to meet the needs of a pandemic that had a response based in social distancing, risks of gathering in spaces with other patients especially, and a lot of uncertainty as to what might be coming. Can we go back to in-person care? As we start to reopen and increase in-person care again, there's a number of new constants in our environment, beginning with facilities, utilizing check-ins and screenings. You may be seeing this in your practice already. For example, we developed an application utilizing QR codes that make re-entry for staff coming in and out of our buildings multiple times a day more efficient. The next will be our expectation that we will have persistent use of high levels of PPE to protect our healthcare providers. This is a new normal that comes with its own challenges, especially discomfort during long days seeing patients, as well as understanding how we will have long-term access to PPE. There's also a continued need for rapid testing, especially with the fall coming and the need for differentiating flu and COVID. We will have to meet the testing demands at a variety of different locations to enable care for our patients. And of course, the challenges of physical distancing, which are going to impact all clinical care settings, but may especially be disruptive in dialysis centers where space may be limited, but patients' demand will stay constant. So there's absolutely no going back. This is a quote from CMS Administrator Seema Verma that was in the Wall Street Journal in April of 2020. And it references the changes in CMS coverage for telehealth. Unfortunately, regulatory uncertainty creates challenges for providers, especially as they consider new workflows or technologies investments. But we do know that patients and providers have now tried telehealth, and in general, they want to use it more. And especially, as I mentioned, in a fall season that will provide challenges for infection control, it will be important for us to have this tool to meet our patients where they are. But things are moving past, and it's possible, based on reports from HHS even today, that by the time you watch this, new telehealth regulations may be in place. Some concepts that are being considered across the country that will help us meet the needs of a new version of care, a new time in care, are quite varied and very interesting. So some of the things I'm reading about today are actually providing drive-through care, where patients don't have to come into an office or exam room setting where they potentially contaminate an area that reduces turnover of our clinical spaces. Especially important for respiratory symptoms, but it may also be important for patients who just don't want to enter that type of environment. So we'll have to think about how the location of services will evolve. Obviously, an examination in a car is not for all patients, but it's something that we need to think about. The way we've done business before may need to change. I think there's going to be a significant role for walk-up windows for care as well. especially in urban areas where there may be less people with cars, less patients utilizing cars. These could be perfect tools for an encounter that occurs post a televisit. So things start online and then shift to in-person care. And a patient could stop in and get a strep swab or have their lungs listened to if that was not available through video. There will be a further shift to care at home, and I believe there'll be a big role for home dialysis and other treatments. And surely 5G will help us bring new technologies, although that may be a few years away. We'll really have to see how technologies like augmented reality, virtual reality, and even technologies we haven't fully be used optimally, and how will we be paid for the services provided through these vehicles. At the same time, we have to be careful and we have to maintain the values that are driven by our traditional doctor-patient relationship. So it's important for us as we develop these new tools to keep our patients at the front and center. So a new normal. I'll leave you with some thoughts around a new normal that I'm pretty confident you will see emerge. There will be more telehealth, there will be more remote monitoring, and there'll be more options for patient access. I think these simple tools will include text messaging, more phone consultations, more video, both in synchronous and in asynchronous environments. There'll be new demands from clinicians for care delivery that improves work-life balance. Now that we've had the opportunity to see patients from the convenience not only of patients in their own home, but also a provider in their own, I think we'll see that the future of physician work could be altered. And it could be very reasonable for a physician to have a practice where 1 to 2 clinic days are at home. There's so many benefits from a work-life balance perspective and a cost of care that would allow us to expand access. Often we are limited by exam space, but now we could provide new capacity for care by sharing exam space and utilizing the virtual space to help manage those patients who can be treated through that modality. And of course, there's the benefits of reducing the challenges of commuting time and other expenses related with traveling to an office. There is going to be a renewed emphasis on utilizing technology to address healthcare disparities for sure. These have become especially apparent and glaring during the time of COVID, and we will have to meet the challenge to respond to these healthcare disparities and see how technology can be enabling. I'd like to thank again the AAKP and GW for allowing me to participate in your conference today.
Dr. Sikka, thank you so much for your presentation today.